So this presentation is on factors which drive radiation use during fluoroscopic procedures. Simple cause and effect diagram. That system performance is driven by methods, machines, milieu, and manpower, and that performance leaves traces in the radiation metrics that we observe, whether it's fluoroscopy time, reference point, or Kerma area product. So the methods, the task difficulty, a lot depends on the patient. Are they large or small? Their physiology? How difficult is the procedure? Well, a lot of that has to do with what type of procedure it is. A TIPS procedure is clearly much more complicated than the average PIC. So we expect different radiation metrics between TIPS and PIC procedures. Machines. What is your fluoroscope and how is it set? What are the default settings, the programs that are loaded at the start of the procedure? And also, do you have ultrasound available as an alternative method of driving a procedure towards the end? What about your devices, the contrast agents, your catheters, your guide wires? We know if you don't have your preferred catheter and guide wire, it definitely impacts performance during that procedure. The milieu, the environment that you're working in. Are the monitors well lit? Are you working in an environment that's conducive to doing these procedures? And what about distractions and availability of prior studies? Prior studies we'll emphasize a little bit later in the presentation. Manpower. We like to focus on the primary operator and their experience, and we know that you can actually degrade performance if the primary operator is fatigued. But what about the team, the technologists, the nurses, and even the patient themselves that are participating in this procedure? It all comes together under manpower. So task difficulty. When we're doing fluoroscopic procedures, the images themselves are used to answer questions that arise during the procedure. And so the number of images and the information embedded those images is a measure of the complexity and the number of decisions that occur during that procedure. And so while fluoroscopy time is not a good metric for measuring radiation safety, I tend to think that it has substantial utility as a first approximation of procedure difficulty. If you look at this graph, fluoroscopy time in seconds on X, in procedures completed, the percent, we see that ports typically are completed in a minute or less of fluoroscopy time. It's a simple procedure. There's not much need for fluoroscopy monitoring. There are not many decisions that need to be monitored and answered. IVC filters, series of additional questions that come up during the procedure, and that requires additional fluoroscopy images. For PCNs and transjugular liver biopsies, a little bit more complicated. You start to see the graph shifting towards the right, and it starts to spread out a little bit further. Declots, and then you get to the complex procedures like TIPS and fibroid embolization, where it's pretty rare to see a TIPS procedure in less than 10 minutes of fluoroscopy time. 20 minutes is common, 30 minutes is not uncommon. And so you see more and more variation because these procedures are longer and more spread out. Dose per image. So I like to think of how much information is embedded in the image, and I've manipulated an iconic image to really remove some of the information. So most audiences will recognize this image at 75 by 75 pixels. Clearly 300 by 300, it's sharp. There's not much reason to go any higher than 300 by 300, and actually some audiences will recognize this image at 18 by 18, but I think very few recognize it at 5 by 5. And so the point is that the amount of information and radiation used to acquire the image are linked. So as we have more and more radiation and we have greater signal to noise and we populate more pixels, that requires more radiation dose. We have more and more information available that allows one to make good decisions during the procedure and conclude the procedure with the desired result. So at the very lowest levels, the image doesn't add anything. Okay, there's not enough information to really change our pre-test probability of what was going on inside this patient. And then you get into a steep slope where at either 18 or 75 pixels, there's enough information to understand what's going on, make a decision, move on with that step of the procedure, and drive the procedure to its completion. Going higher than 75 or even higher than 300 tends to flatten out. There's not much advantage to increasing the amount of radiation used beyond that point. And so this is, to me, the difference between image utility, which is, does the image really satisfy a need to make a decision during this procedure, versus image quality. Image utility has this sigmoidal curve. Image quality would be, well, the number of pixels and resolution and the signal to noise within all those pixels. It's going to be a different shape curve. It's not going to have this sigmoidal character. And we know as we're working in these procedures that we've got enough information to drive the procedure through this step. Let's finish it and move on to the next step. And so dose per image is definitely dependent on two factors. The first is the protocols, the machine settings in that automatic exposure control circuit that determines how many photons must reach the detector in order to terminate the acquisition. In fluoroscopy, we're working at very low levels, 0.02 to 0.04 microgray per image. Digital spots and DSA is about 100-fold higher for a typical setup in a room. And when we look at how imaging is done during this procedure, the vast majority of images during any procedure are fluoroscopy. So the majority of intraprocedural decisions are driven by these very low dose images, and it's only a small set of intraprocedural decisions that require shifting to the much higher DSA. The other factor which drives dose per image is patient diameter, the attenuation of the beam. And if you have a monochromatic set of photons, they're going to obey the Beer-Lambert law, where it's a logarithmic relationship between how many photons have to go into a patient versus how many get out and reach the detector. And it's the difference in this path length that has a marked impact on how many have to go in to reach the other side. It's also the concentration of any attenuators. If you're trying to penetrate a contrast-filled bladder, you're sending a lot of photons that'll be attenuated and not reach the detector. So with this dose per image, I've got two images. One on the left is 0.24 micrograys at the detector, terminates the exposure, and then the one on the left is 2.4 micrograys. And if you look closely, you can start to detect that there is a difference. The bones in panel B, a little less distinct at the edges, but it's a perfectly acceptable scout image for this tube check. Tells me where the tube is. There's some contrast from prior studies in the field, but this is all I need before I go to inject the tube. There's not much reason to acquire more detailed images at this point. A low dose image has satisfied the need. It has the utility that we need. The shifting to Manpower, this curve shifts back and forth. Okay, the sigmoidal curve. I know when I was early in my training that I would use more fluoro frames, I would use more DSA. I wanted more information before I would finish a procedure. And with time, gradually shifting the curve leftward. We definitely see it, our residents and fellows, as they progress through the year. They get more and more skilled at stepping off the pedal and taking other steps to reduce radiation use both to the patient and to themselves. Talking about Manpower gives me an opportunity to talk about the difference between planning and execution. Psychologists that study movement would say that every voluntary movement has two phases. The first is planning, and the second is execution. And while we get so good at these sequences that they seem all to run together, there still are micro steps of planning and execution, even in what seems to be a smooth series of events. So Manpower also allows me to talk a little bit about skill in planning versus execution, because psychologists would tell us that every voluntary action has both a planning and an execution phase. And James Reason studied this and said, well, human error can be attributable to problems with planning and problems with execution. And so clearly high skill in planning, high skill in execution gives us the highest probability of the desired result. Low skill in execution coupled with high skill in planning actually still works, because skilled plans anticipate that there will be problems with execution. We have this in our image-guided procedures all the time, that I've tried to advance the catheter or guide wire to a certain destination, but it doesn't get there for one reason or another. But I can see that, and because I've planned on monitoring progress, I can now step in and change the next step in the procedure to get the catheter guide wire where I want it to be. Low skill in planning coupled with high skill in execution is a horror film. It's Friday the 13th, part 27. Jason somehow has again escaped. He's roaming the neighborhood, and there are the teenagers huddled around the TV. The news flash comes on that Jason's out. There's blood dripping from the ceiling, and there's a thump. And one of the teenagers says, I'm going to go upstairs and investigate. Everyone in the theater knows Jason is upstairs, and it's going to be a bloodbath if you go upstairs. But that is high skill in execution, able to go upstairs, but low skill in planning. Didn't put two and two together to recognize that Jason was in the neighborhood. Low skill in planning and low skill in execution actually allow serendipity, where two wrongs sometimes can make a right. So Dan Pikus, one of my mentors, taught me long ago that always be thinking about what you're going to do next if what you're currently trying fails. What's your plan B? And when you formulate plan B, you've actually gone a step that you're actually thinking about how to monitor the success of plan A, and what criteria are you going to use to change to a different type of catheter, to change to a different guide wire, change your access, do something else to change the circumstances so that you can proceed. And again, it emphasizes the importance of planning in procedure outcomes, and especially with radiation use. Teamwork, when I talk about Manpower, clearly depends on communication. Claude Shannon is now one of my heroes. He developed this fundamental theory of communication, and he recognized that information is defined by its ability to reduce uncertainty in the receiver. It's not so much about what I transmit, it's about what the receiver at the other end decodes in my message. And so he had this model where a message is encoded by the sender. It generates a signal. It might be words, it might be keystrokes, it might be hand signals. That signal usually is degraded somehow in transmission. But when it reaches the receiver, it's decoded, and that reduces uncertainty. And there's often a feedback channel that the receiver can use to send a message back to the originator to say message received, acknowledged. And a great example occurs all the time in our fluoroscopic procedures. It's an abdominal angio. This is a large patient having trouble with seeing the catheter tip. And I decide that I need to tell the technologist, please collimate and center. So I form the words of center on the catheter tip, collimate from side to side, but unfortunately it's always a noisy room, and the technologist who's standing by the controls here is center and collimate. But because this technologist and I share a mental model, we have a shared understanding of this procedure, She recognizes that centering and collimation, oh, that would help. And pretty soon I see the collimators coming in, the C-arm shifting, and that's all the feedback I need to know to realize that my message has been received and decoded properly. So it emphasizes the importance of shared mental models amongst members of our teams. And if you've worked with people that aren't on the same page as you, that you don't share a mental model, you recognize how that drives up radiation use during your procedure. Teamwork also depends on culture. Are you at the low end with a weak safety culture? Or hopefully you're at a robust safety culture? Well, you can look at what are the beliefs. If radiation safety is always somebody else's responsibility, you're at the weak side. If radiation safety is everyone, okay, the primary operator, the technologist, the nurse who's sedating the patient so that they can still follow my instructions and hold their breath when I need them to. The attitudes. If you have an attitude that, well, these protocols, we just did this for the Joint Commission, it was years ago, versus, we're watching this and we're constantly updating because we want to be getting better. The values. Complications. Well, complications, clearly, we're going to have a couple skin burns. Complications, it's just part of what we do. Well, it shouldn't be okay for all of us to work in a place where it's okay for people to be hurt. There needs to be a conscious and ongoing optimization of risks and benefits with every procedure. And finally, event reporting. Why report events? Clearly, they're just fodder for the lawyers. But no, we report events and we actually track our near misses as well because we use that data to improve performance day in, day out. The machines that we have for our procedures, critical. The imaging protocol and especially the default settings. Back in April 2011, we were tracking dose and we had a low dose protocol that was actually installed in the machine, and occasionally it would be used, but it wasn't used consistently or reliably. That low dose protocol had a reduced frame rate and we had also reduced dose per image, but the problem was it wasn't being used, and we found that it wasn't until September 2011 when we made it the default protocol so that when you walked in the room, the machine was set to low dose. If you wanted to up it, if you wanted to increase the frame rate or dose per image, perfectly capable, welcome to do it, but we're going to start at low and really getting people to start working through low dose imaging and finding that more and more procedures were completed with low dose throughout their entirety. And it really came to what drove it was we found that when we started at medium, it was relatively rare for someone to sort of recognize halfway during the procedure that the images were better than they needed and drop it. It's much easier to say these images aren't quite what I need for the procedure and move from low to the medium setting. The machines, if you have ultrasound available, it clearly impacts radiation use. Here it's just in fluoroscopy, the number of frames, the fluoroseconds, and we see a pretty dramatic difference between our central lines that are done with fluoroscopy versus those that are done with ultrasound. I'd like to emphasize the importance of environment, particularly having prior imaging available when you're doing a procedure, because that can help you avoid relearning what is already known about your particular patient during the fluoroscopic segment. An example that we've heard from MD Anderson is that they're no longer using DSA acquisitions prior to filter placement. That they've recognized that a recent CT can tell where the level of the renal vein is. It also allows them to define IVC anatomy, and they can really go with just fluoroscopy only during a simple IVC IVC filter placement. And we decided we'd try that. And so here's a filter placement with 3.3 milligray. The 50th percentile for our filters is 39. So this is tenfold lower than a typical IVC IVC filter placement. And when you look through the timeline for this 10 to 12 minute procedure, you see a little bit of fluoroscopy at the beginning, which is typically associated with coming down from the jugular into the IVC. There was a fluoro acquisition with contrast injection to prove that there wasn't clot in the IVC, and there rarely is. And then there's a longer acquisition at 1640, which is the actual deployment of the filter. So there's a continuous monitoring while the deployment sheath is being retracted to deploy the filter. And finally, a final couple of fluoro frames assessing filter position prior to removing catheters. The environment also includes the lighting and the positioning of equipment. Is it an ergonomic environment? And if you want a non-ergonomic environment, go down to the operating room where they're doing a fluoroscopic procedure. And they've brought in the C-arm, the screens are off to the sides, the lighting is often set up for the anesthesiologist rather than doing the procedure. You really start to appreciate how good we have it in an interventional suite. The other issue in the environment are distractions. Our ability to multitask is largely a myth. Interruptions are a frequent contributor to error. If someone sticks their head in the middle of the procedure and asks me about Mrs. Smith, her INR is 1.01, is it okay? I have to basically drop what I'm thinking, where I am in the procedure, load Mrs. Smith and the INR algorithm and quickly come to 1.01, of course it's okay. And now I pick up where I was in the procedure. When aviation incidents are studied, it's not uncommon that the pilots are going through their checklist. They get a call at item number 5. They answer that call, and when they pick up the checklist, they hadn't completed 5, but now they're on 6. And so there's actually an incident where they forgot to refuel the plane because the call came in at the wrong time. So in summary, a series of different factors drive radiation use during our fluoroscopic procedures. These factors all contribute to system performance, and their footprints are all over our measures of radiation use, whether it's fluoroscopy time, reference point area kerma, or kerma area product. And I hope that having a better understanding of the different factors and how they drive performance during your procedures can help you improve in the future. Thanks.